So good afternoon, everybody. Thank you very much for joining us this afternoon. We'll try and just turn off the ding dong in the background. I think that's an astonishing number of people joining. I think we had about 500, but actually we have a very large waiting list, and we'll maybe look to see if we do another one of these. So I'm Dr Leach. I'm a GP here in Worcestershire. So I practice at Dartnell House Surgery in Bromsgrove. It's a fairly traditional surgery, but we look after 6 nursing and care homes. We've also seen quite a number of patients here in the West Midlands with coronavirus COVID-19. So, we can speak with quite a degree of personal experience around this, as well as obviously what we're doing from the college perspective. One of the things that we've been very clear about is trying to make sure that we're able to assess patients who might have COVID-19, and also to be able to differentiate those patients from others, because clearly they're not the only patients that we'll see. So over the next sort of half-hour slides and then the Q&A, I've got 2 very senior colleagues who are going to assist me with this. One's Dr. Alison Tavare, and the other one's Dr. Simon Stockley, and I'll ask them to introduce themselves in a second. I think we're particularly grateful from the RCGP perspective for the work of the Academic Health Science Network, and we've been doing this jointly. So I hope you're going to find the afternoon useful, both for you professionally and also for your patients. So if I could ask Alison to introduce herself first, and then we'll move to Simon.
Thanks, Jonathan. As Jonathan said, I'm a GP, and I'm a GP working in Bristol, but alongside that, I'm one of the primary care clinical leads at the West of England AHSN, and my role there is to look at the work supporting the identification and management of the deteriorating patients. That's why this is particularly relevant. And I've been working with the AHSN network, looking at how we can support GPs, particularly with related to COVID.
Hello,
Simon.
I'm Simon Stockley. I too am a GP in the northeast of England. I've been the RCGP's clinical champion for sepsis and latterly lead for acute deterioration. I've had a particular interest in emergency planning and the very sick patients for a number of years.
So thank you very much. Just in terms of how we're going to do this is that, as you'll see, Simon and particularly Alison at the beginning, we've got a few slides which we prepared. And then afterwards, there'll be opportunity to pose questions. So our colleague Catherine Dale from the Academic Health Science Network will be collating those, so that if you've got those, put them in the chat as we go, and we'll collate those at the end. We hope we'll be able to answer most of them. I'm certainly involved with a lot of the national planning, and obviously we're aware of there may well be people watching this, not just from England, but certainly across the UK. So we'll try and sort of make sure that we pick up things from Wales, Northern Ireland and Scotland. And as it goes onto YouTube, we might also think about international. So without more ado, I'm going to hand over to Alison in the first instance. Could we have the next slide? So what we're going to particularly cover is the clinical features of COVID-19, how you can make clinical judgments. I was in the surgery yesterday doing exactly this alongside my colleagues. We will discuss the role of News 2 in general practice. It's an interesting area around how this may or may not be of value, and we'll come back to that. A particular thing is around the use of pulse oximetry, which I think again will be interesting. And then, as I said, we'll move on to question and answer at the end. So without more ado, could we go on to the next slide? And then what we'll do is I'll ask Alison to carry on, and then I'll come back to this at the end. So thank you very much. On to you, Alison.
Thanks, Jonathan. Well, I thought I'd kind of start by really expressing my surprise that I'm here, because at the beginning of January, I'd never heard of COVID-19, and I'm sure I'm not, that's the same for everybody. And I just can't believe how, in all my time as a GP, I've never been involved in anything like this, which has had such considerable impact on me, all of us personally, but has also had impact on our clinical practice. And As one of my GP colleagues said this week, we're going to have a new normal. And it's certainly going to be like this. I think general practice will never be the same going forwards. So what we're hoping to do today is to share what's been going on in secondary care, because there's lots of learning there, but there's been limited information on mild illness in the community. And actually, it's a challenge how we as GPs can identify the sickest patients. So we want to share the learning that's coming out from secondary care, but also raise aware of emerging themes in primary care to try and equip you in your clinical roles. Thank you. Next slide, please. So this is the first time I really understood a bit more about what was going on in China. It was a paper shared with one of the colleagues at Health Education England. And I was really shocked to see that how many patients who are being admitted hadn't met the criteria for sepsis, 59%, and that 54% had respiratory failure. And the other thing I noticed was that the SOFA score, which basically includes all patient physiology along with blood tests, showed that the higher the SOFA score, the greater the odds of death. And I know that's not surprising, but it reinforced to me that deteriorating physiology could be a way of predicting who's going to be sickest. But as a GP, the bit that I found most surprising, which now has become a recurrent theme, is the fact that patients with COVID first present with fever and a persistent cough, and they seem to rumble along for a few days, being moderately unwell in many cases, and then something happens and they deteriorate very quickly, often about day 6, although from experience it's sometimes people are a bit later. And it's those clinical observations that we want to share with you today. Thank you. Next slide, please. Next slide, please. Oh, sorry, apologies, we went back 2 slides. Could we go back to the previous slide? So, as I said, we've had a lot of information come from secondary care, and this has been shared by colleagues from NHS England, in particular Matin Ardikim, who's one of the national deterioration leads, an ex-GP, but now works in the AMU, has been really supportive. And it's been very helpful to know all these symptoms. Breathlessness obviously is the most significant symptom. And Simon's going to talk later about how we can kind of clarify the significance of these symptoms when taking histories. But it's difficult for us to have objective evidence. And there are also issues such as the temperature isn't predictive, very much in the way of sepsis, that people could have a high temperature, but they may equally have a low temperature. So what I'm hoping to do is actually share an overview of patient physiology and how that can help you and support you in your decisions on who's sickest and how to manage them. Thank you. Next slide, please. So I thought I'd start with some UK data, in particular this data which has just come from Bristol, and thanks to the team at university hospitals. They looked at 69 COVID patients who've got completed admissions, i.e. are no longer in the hospital. It's not going to surprise you to see that 67%, median age 67 and 63% male. The outcomes, 60% discharged, 33% died, and from the data I've seen from other hospitals, that seems quite consistent. 7% transferred, and I hadn't really heard much about ECMO, extracorporeal membrane oxygenation, but a lot of our really sick patients are having to go to one of the 5 regional centres, and a number of them have been transferred from Bristol for that. But for me as a GP, the most relevant observation is that the median hospital admission news was 8, really very high. I've only seen a patient with a news of 8 on a few occasions. That's in the community. And also the median lowest pre-hospital oxygen saturations were 86. And again, this is really marked abnormal physiology, which Simon's going to go into in more detail. Next slide, please. So obviously I'm going to be talking about patient physiology, but before I do that, I need to be very clear on the RCGP position on news, because there is no validated scoring system for COVID. It's a new disease and we haven't got the evidence base. Physiology can help us track changes over time, but we have to be very clear that looking at physiology can help you, but clinical judgment is absolutely paramount in what we do. Thank you. Next slide. And this view on news and the lack of evidence for COVID has been echoed by Trish Greenhill and the Centre for Evidence-Based Medicine at the University of Oxford, who undertook a review of the current literature. And again, they said there was no data of value for news in COVID in primary care. They also raised the concern that actually, because we're not going to be seeing patients face to face on many occasions, we're not going to be able to take a full set of observations. However, they did say that key to the detection of deterioration is comparing the current news or news 2 against previous sets of vital signs. So looking at physiology has value, but it's actually the actual news itself we have to have some caution. And Trish also recommended, and I would certainly support this, that urgent research is needed on the use of prognostic scores. And I've just noticed she's got ethical approval to undertake this work. Thank you. Next slide, please. So with those caveats there, I thought I'd just mention a bit about news 2. Apologies for those of you who already know about the National Early Warning Score, but I just thought it'd be helpful just to clarify it. And I would also explain how news National Early Warning Score has recently been updated to news 2, so sometimes use them interchangeably, but the principle remains the same. News was developed in conjunction with the Royal College of Physicians on 6 physiological parameters: respiratory rate, oxygen saturations, blood pressure, pulse, level of consciousness, and particularly new onset confusion, which is significant, and temperature. Each parameter is given a value, and then it's been totaled to give a score, which is the National Early Warning Score. And so it's an aggregate score which looks at a number of minor deflections, which I think is one of the values, rather than as it used to be many years ago. I'd admit a patient for chest infections and I'd pick one thing, such as their very rapid respiratory rate, to support my decision to admit. So why do they use, what's the value of news 2? It's threefold. One is looking at the acuity of the patient. And so the sicker the patient, the higher the news. And we've certainly found that that's the case in primary care. We recently had a paper published in the British Journal of General Practice. The higher the news, the sicker the patient, and the more likely they are to die. It's also a common language. So if I have a patient with a news of 4 and Simon has a patient with a news of 6, it's likely that his patient is sicker than mine. And thirdly, the news can also be helpful for tracking and triggering. So if you monitor the news over time and the news score goes up, then that can trigger interventions such as a more frequent review. And in the context of COVID, if we're looking at patients having multiple reviews, what's happened to their physiology? So just a couple of exclusions. News is not valid for children under 16, not valid for pregnant women, and not valid for people who have got spinal injuries causing autonomic problems. Next slide, please. So as I briefly mentioned, I've been very involved in looking at deterioration in the west of England, and in 2015 we started a regional collaborative to improve the quality of safety of patient handover. So what we started to do was recommend that GPs would make a decision to admit a patient and then calculate the news, because there was no evidence for the use of news in the community. And the idea then was that we would be starting the track and trigger element of news one step earlier. And this was the first time we found it really worked. Paul was a patient who presented to have a dressing change, so he hadn't presented as acutely unwell. The nurse was concerned. He was seen by the GP, John Rees, news of 7, so obviously unwell, diagnosis of sepsis made. By the time the ambulance arrived, his score had gone up to 8. By the time he arrived in the ED, his news was 9. So objective evidence he was unwell, objective evidence of clinical deterioration, and it prompted a prompt management of his sepsis, and he was home within a few days. Thank you. Next slide, please. So that was our initial vision, but with time, and I'm sure many of you are aware of it, news has started to be used in many different ways, and the ambulance are now starting to ask for news to help them prioritise which patients are sickest. The hospitals are similarly asking for news, and using that, they can try and prioritise and work out which patient should be seen at the right time in the right place and by the right person. So these numbers I'm giving are very broad brushstrokes, but News 3 AMU, 7 acute assessment, and 5 acute assessment and 7 as ED. But alongside this, clinical judgment remains absolutely paramount, because if someone's got central chest pain, it doesn't matter what their news is. If they've got a stroke, it doesn't matter what their news is. And the other caveat, which I have to be clear about in COVID, is that I've shared those numbers, but they're not going to be relevant to give you an idea of what's been happening. But actually in COVID, we're not going to be able to take full sets of observations. We've also got the unpredictability of COVID, that it's an illness when people seem to deteriorate over a quite short period of time. And there's also the balance of priorities, whereas before you'd send a patient in because obviously treatment was appropriate, but now is that right? Because what's the care that's going to be offered in the acute sector with all the increased possibility of overcrowding? Thank you. Next slide, please. So that's the idea behind physiology and COVID, and just giving you an overview. Does it actually work? And yes, it certainly can. I've been shared, this case has been studied, I've been given permission to share this very kindly by John Caldwell, who's a GP in the Northwest, who's done a lot of work on news and its use in out of hours. He developed COVID, was monitoring his news 3 to 4. And he'd actually been in contact, said to me that he thought he was getting better. Then he suddenly deteriorated over a few hours. News of 7 and admitted, and COVID confirmed. He's now well and in fact is back to work. So I mentioned that story as showing how the news could identify the deterioration, but I also just wanted to highlight another emerging theme, that a lot of people with news are, with COVID are getting clotting problems, and John certainly had a raised D-dimer and was treated with low molecular weight heparin, which I think is going to be something that we may be noticing in our patients coming home. Thank you. Next slide, please. So as I said, COVID news can really help, but it doesn't help for everyone. And I completely agree, clinical judgment is paramount. So you have to know what's normal for your patient. For many years, I was a GP, medical officer in professional cricket. And as part of that, I used to undertake annual checks for the cricketers. And as you can see, they're young, fit men. So it wasn't unusual for them to have a normal news of 3 because of a low heart rate. And I shared this at a recent workshop, and one of the GPs there commented, if this young player got a heart rate of 88, if he were unwell, his news would actually fall. So you have to look at it, the context of what's going on, and also look at the individual observations within the news, because if his heart rate went up, I would also expect his respiratory rate to go up. So it's very important to look at patients' physiology in the whole, and it's another reason actions can't be ascribed to scores. Next slide, please. And alongside that, of course, is the physiology of our residents in care homes have often got long-term conditions. And this is a story case shared by one of my nurse practitioners, non-COVID, but this gentleman had been unwell, his news was 3, and when she went in the next day, his news was 8. So objective measurement of clinical deterioration, which really helped her. She was also helped by the fact he'd got a DNA CPR in place. And I would suggest that if you haven't done it already, look at the advanced care planning. Respect is one summary plan that's available. But what do your residents want? What is right for them? How can we deliver the best patient-focused care? And also, how can we look at physiology in care homes going forward, particularly in times of COVID, when we know that there are a lot of deaths in care homes and the care home staff are under huge pressure? And can your care home staff start measuring physiology? There's been a lot of suggestions, so I'm going to talk about it later. Could they be trained to use pulse oximetry? The pulse oximeters are going to be bought and distributed, so that may be a possibility. Health Education England have produced videos which can be used to train staff remotely on how to take observations. Just think how much easier it could be if a care home staff, you're monitoring somebody remotely and a member of staff rings up and says that the patient's oxygen saturations were 92 one day, and then the day they're now 88. That gives you that objective measure of deterioration. And while you may feel that a lot of patients have a high base news level. In fact, that's not the case. Robert Barker and colleagues in the Northeast looked at over 19,000 news observations undertaken in care homes, and 66% of the residents had a news of 2 or less. So next slide, please. So obviously not all abnormal physiology is COVID related, and I'm sure that you've seen some of the reports that not only is there an increase in deaths related to COVID, but there's also an increase in deaths from non-COVID causes. And obviously it's going to be looked into. I know Public Health England are investigating this already, but I suggest there are two themes. One could be the late presentation of patients with other illnesses, so they're concerned that they don't want to put themselves at risk going to hospital. And one of my ED consultants describes how she saw somebody a few days ago who'd fractured their ankle 10 days previously, but was too scared to come into the ED. And then there's also the additional complications that because patients are presenting late for perhaps non-COVID related causes, their physiology is so challenging, it can be very difficult and complex to work out what's going on. And other secondary care colleagues have shared stories of perforated DUs, which they haven't seen for some time, and situations such as bowel problems, obstruction. So apologies for messages coming through. So those are the concerns with the non-COVID related deaths. And I'd like to give you an example. Could I have the next slide, please? And this is a case that I was involved with recently. So an 84-year-old woman with known paroxysmal AF, treated on bisoprolol. She had a history of dizzy turns, been investigated and no cause found. And she also had a pulse oximeter just in case, so she could measure her observations if she'd come unwell with COVID. So a few weeks ago, felt very unwell, checked her pulse, and actually it was 29. By the time she called the ambulance, called NHS 111, the ambulance was sent. By the time they arrived, she was actually in fast AF. She was admitted to hospital. By that time, her news was 3. She was treated with bisoprolol and returned to sinus rhythm, but arrested 6 hours later. And tachybrady syndrome was diagnosed. Pacemaker was inserted and she was home within 72 hours. And I share this for a number of reasons. 1, clinical judgment, again, remains paramount. 2, you can't ascribe actions to score. She only had a news of 3. And thirdly, an unexpected benefit of COVID that she had a pulse oximeter at home because it had been previously impossible to work out why she was having dizzy turns. So that's a real quick overview of patient physiology. I hope it's helped you show how looking at patient physiology and abnormal scores can make you think, is this patient sicker than I really understand it? Can you use, by looking at patient physiology, can you identify deterioration, particularly if we're viewing patients who've got COVID? And by using patient physiology, how we can then use this to communicate better with our colleagues. But as I said, there are reservations. That's because COVID is a new disease. It's presenting in very unpredictable ways. So clinical judgment remains paramount. And we need much more research and evidence going forward. So please, if you have any opportunities to get involved in research, that would be amazing, because we as GPs need to be being involved in this evidence going forwards. So thank you very much. And I'd like to now pass over to Simon, who's going to give a more detailed overview of the respiratory physiology related to COVID.
Thank you, Alison. That's been great. And we've got the next slide. What I want to do is to build on our understanding of what clinical judgment really is and what it is that we respond to when we say, well, I just kind of know sick when I see it. We've all been in that situation of having a really sick patient come in, and before you've been in the room 30 seconds, you're thinking, this guy's not well at all, he's going in. But how many of us actually know what it is we're responding to when we see that patient? And if we understood better what it was we respond to and what that sort of inbuilt visual memory is, we might actually be able to go actively looking for it with a little bit more accuracy, and maybe spot it when it's being disguised by other features. And certainly that's what I was taught. You will know sick when you see it, and once you've seen it, you will never forget it. When I started doing the sepsis work, we had a careful look at this, and the three most predictive things about being unwell are your respiratory rate, your perfusion, your blood pressure essentially, and altered cognition. So I usually tell the story of a 69-year-old college lecturer who presented to me with his wife, and I'm sat in my consulting room thinking, well, he's a bit slower coming into my room. I wonder what's going on. And he sits down in my chair, puffing a little bit, having struggled with the 20 yards from the waiting room. I look at him and he looks pale, and I rather think he's clammy as well. And I ask him, what can we do for you? And this 69-year-old college lecturer looks at his wife as if to say, what is wrong with me? And I've got all three there. I've got somebody with an elevated respiratory rate, who's poorly perfusing, and whose cognition is way off what it normally should be. I already know he is sick, but I know it because I have observed his physiology without actually measuring it. Next slide. Next slide. So what can we go back one? We've jumped to. What is it in the story that we listen to that might help us tell us whether it is COVID or non-COVID? This is what NICE came up with, and I won't tell you what the symptoms of bacterial pneumonia are, but COVID pneumonia, typically unwell for a week, that muscle pains and lack of sense of smell seem to be common symptoms, and although they are breathless, they don't have any pleuritic discomfort, and typically they may not be using their accessory muscles to assist respiration because they don't have bronchospasm as a major feature of their illness, and they may have exposure to COVID. So there is a slightly different history that should set you on your guard compared with bacterial pneumonia. Let's go to the next slide, please. This is what they felt about oximetry. They felt that oximetry below 92% or 88% in patients with significant existing lung disease identified seriously unwell patients. They recognized the difficulties that GPs would be having in doing all the observations remotely. They had a good look at the Roth score, which was aimed to be a proxy for oximetry, and felt that actually the evidence was very weak and wasn't reliable, and indeed there were case reports of problems with it. They felt that the use of news may be useful, and they went no further than that. But they also said that face-to-face consultations should not be undertaken simply for the purposes of calculating it. So if you can do it by other ways and are already significantly concerned, then it's not advisable to bring somebody in simply to be able to measure a blood pressure or oximetry. Next slide. So, oximetry is a measure of effective respiration. It doesn't tell you how much you're, how hard you're working to breathe, but it tells you whether what you're doing is effective. What we find with COVID, and our hospital colleagues have been telling us, is that there are a number of patients who on first glance don't appear to be that sick. They may well be have an elevated respiratory rate, but as I said previously, they're not working hard at their breathing. They're not using their accessory muscles, so they don't look like out of breath asthmatics or COPD patients. They're just unwell. And when you stick an oximeter onto them, they come out with oxygen levels in the 80% mark, and are really very sick, some of these, at the time they present in hospital. And also that the ones who are presenting late and hypoxic are doing less well. Seems to be a pattern, and that seems to be a pattern, seems to be a theme in COVID. We don't know, we don't have solid research, but we're working on impressions a lot of the time. So next slide, please. As I say, the ROTH score is no longer recommended. Similarly, app-based oximeters, smartphones can or have been tried to use their cameras to be able to detect oximetry, and it's certainly currently viewed as unreliable for medical use. In some areas, they've been trialing home delivered oximetry, either by somebody driving to the house of a patient of concern and measuring their oximetry, or leaving an oximeter on their doorstep in a Tupperware box. And this gives the phoning or video consulting clinician a little bit more information and a little bit more objectivity as to how unwell people are. And it's certainly being tried out in my area. We don't have any indications as to how successful that is proving. One of the tips on the ED consultants is that in patients who have a normal level of oximetry, say greater than 96%, if you exercise them, walk 40 steps or sit up and down for as many times as you can in a couple of minutes, and they desaturate, that their oximetry falls as a part of that, that is a bad sign, and they need close monitoring and probably admission, because they're coping sitting still, doing absolutely nothing, but the minute they move, they become physiologically unstable. And that is something that is more difficult to achieve in primary care. Next slide. We fairly early on had a look as the RCGP as to where GPs add value for patients with COVID. And patients with COVID can come into our GP delivered services either through 111 or self-presentation to general practice. And some of them, it's fairly obvious that they're doing absolutely fine and there's not a big problem. Some, it's very clear that they are unwell, and those are the green and the red routes. And then the place where we feel GPs add most value is in the clinical assessment of those who are in the middle there. And particularly this sort of grey area. Next slide. This is it in a bit more size so that you can see what we're talking about. This is the grey area. Some of them, when you've been able to video them or get some physiology off them, it's pretty clear that they're not being adversely affected, that they can do their activities of daily living, that they're peeing normally, that they don't perceive themselves as breathless, or that there are also this red group who are clearly unwell and have markedly deranged physiology. But it's this group in the middle where we're obviously more concerned, where there may be some value in getting physiology or tracking their physiology by doorstep delivery, oximetry and other devices, or seeing them face to face. And that gives you a group who are going to manage fine on their own, go into hospital, and you will still be left with a small group who you may want to either undertake extreme safety netting, maybe supporting that with oximetry, or and certainly having some sort of planned review system. Next slide. Right. So we do strongly recommend the use of physiology alongside clinical judgment. It's useful in that it does give you an objective measurement as to how unwell someone was at the time they presented, because we all know that sometimes patients will go off very fast and the person that saw them last can sometimes cop it for why did you miss it. And if you can say objectively, actually, they really weren't that sick when I saw them, it's a useful thing to be able to say. Calculating news in the face-to-face appointments is appropriate, but not obligatory. The values that are in the news table are a guide to what's normal and what's distinctly abnormal. It's useful, as we've said, as a communication tool and for tracking deterioration. Somebody who had normal physiology one day and now has significantly abnormal physiology may well be on a downward track and may need more active assessment. It provides a structure and objectivity to what you're doing, and increasingly other areas and other clinicians are using this as a tool, and they may come to GPs saying, I've got a patient with abnormal physiology. What do you think, doc? It's down to you. So it's being used by them to identify patients for whom they wish to escalate concern, and can escalate that concern with a little bit more judgment than I'm not sure he's very well. Next slide, please. Given the current circumstances, it's quite plausible that you won't be able to record all vital signs. Blood pressure remotely may be a problem, and that we're not going to do a face-to-face consultation simply to achieve this. And NICE have recognized that incomplete news scores may result as a result from that, and that where you do pass an incomplete news to your hospital colleagues or ambulance service, you should state that it is incomplete. I've done this certainly in my clinical practice on more than one occasion, and the comment was, look, if this person stops shaking, I may be able to give you a reliable blood pressure, but at the moment their news score is somewhere between 7 and 10. The result was an ambulance outside of the door 8 minutes later, which to me as a GP is not a bad result for communicating concern effectively. Next slide. So what are the key messages from today? That the respiratory rate is particularly important in the context of COVID, and that isn't the same as respiratory effort. That oximetry is important where there is concern, as patients may have silent hypoxia. New changes in cognitive function or activities of daily living. So if so, and particularly soft signs, so new falling, incontinence are indicators of systemic unwellness, and particularly in the presence of fever or cough would be of significant concern in COVID. So that, can we have the final slide? We're now into a Q&A session. This is going to be led by Catherine Dale, who's the Programme Director for the Health and Innovation Network in London. Catherine, do we have a first question?
Yes, thanks ever so much. Yeah, the first question is, most of the things that you've been talking about have been about adults. Have you got any comments about children? Simon, could you answer that one? Yeah,
you're absolutely right. What we have talked about predominantly is adults. The same sort of abnormal physiology probably extends down to children in their early teens, but we are not seeing huge amounts of truly unwell children with COVID. We've had reports now of an inflammatory type illness that may be associated with COVID along the lines of a Kawasaki's disease, but we don't know the frequency of this, and we don't know whether it is a causative effect or whether something else is going on to cause it. But the assessment of children is more or less the same. If you have the facilities to do pediatric oximetry, we would encourage you to do that. That we would ask you to look at respiratory rate particularly, and the soft signs, the altered function that relates to cognition in smaller people is again relevant. So respiratory rate, reduced perfusion, and altered performance cognition as appropriate to children is still relevant in this case. Anything more from Jonathan or Alison?
No, I would agree, and it's a very important one that, you know, we obviously do these assessments. And just to give you an example, I was we were all moving into doing lots and lots of video consultations. So there was a young person I assessed. She was 12, actually almost certainly had COVID-19 actually, which was an interesting one. But I was doing that by video. And actually what I was able to do was actually do that sort of clinical assessment using things. So actually I got the mother to take the child's pulse, actually being able to see the young lady. She thought it was great to be able to stick her tongue out at the doctor, which I thought was really good. So actually that was very good in terms of assessing how good her cognition was. And actually just by gently asking mum to lift the t-shirt, I could then see the respiratory rate. So actually, you know, many of us are using techniques whereby we're now integrating video in. And of course, you can do that, not just in a pediatric audience set of patients. And similarly, I've been doing that with adults. And I think many of us have switched wholesale, not just from phone. And, you know, we've moved probably in 2-3 weeks what probably would have taken 10 years in terms of getting technology and things like this. So actually the physiology is right. And of course we can assess many things, not everything, obviously by using the video. And I think that's really where many of us are now going. So Catherine, next question. I think I may have answered some.
Thank you. Thank you, yes. There was a follow-up question actually about mental health patients whose cognitive function fluctuates. And one of you might be able to comment on how COVID-19 is able to be assessed in those circumstances.
I think it can be more of a challenge. I think sometimes it can be okay, and I have done it. It helps if I know the patient, actually, but I appreciate that isn't always possible. And clearly you might be able to see, you know, if somebody's significantly depressed because they're looking down. Obviously, if there's a cognitive impairment, that would be there. Also, you'd be able to see if they're agitated. I have done this where actually it was the carer who had the phone, and that was actually quite effective. But it's perhaps more complicated if you're asking the patient to do it themselves. I think Simon had something to say.
Yeah, I think both mental health and learning difficulties are a challenge to assess in good times for their physiology and acute deterioration. And sometimes it's useful to have talked to their regular carers to say, are they performing as they would normally perform? Is this a normal appearance for this, or are you judging them to be unwell? Do they present concern to you? And even with the learning difficulty patients, some of them have gone to the extent of being able to do their own physiology and use this as to when to escalate concern. And certainly if you've got individuals where this is a consistent problem, it can be of great value.
Thank you. And I would echo that, because the Learning Disability Mortality Review highlighted we should be looking at patient physiology for patients with a learning disability, and that can help when the communication is less clear.
That's great. Another question that's been coming in has been about, you've been presenting what the normal symptoms that we understand are, but there's also more anecdotal reports and reports from other parts of the world about GI symptoms and symptoms around loss of taste and smell. And just wondering, whilst they're not on the significant symptoms lists, have people got comments on that? I think Simon wanted to come in first.
I think what we presented are the symptoms that predominate in those who are unwell enough to get into hospital. And now some of the more minor symptoms that are being described, it's less clear whether they are indicators of people going on to need hospital. But you're absolutely right. Lack of sense of smell seems to be a common feature in people with COVID, but whether it is a sign of being truly sick with COVID, it's less clear, and that's why we've not majored on it.
And the other thing is that there are other causes of loss of smell, and I think that's the other side of this. So, you know, other viral infections, you know, frequently would cause a loss of smell. So it's not specific, but I think that it's one of those things which you might take into account as part of the overall constellation of symptoms. And it might be, as we're ramping up testing, that it might be one of those things whereby somebody might be advised to go and get testing, so that actually we know what we're dealing with. So I think it would be that. And as you just described, Catherine, there are a proportion of, my memory is sort of less than 10%, can sometimes have sort of the GI upset and things like this. So it's, you know, it is the sort of thing to take as part and parcel as diagnostic. But the main things in terms of whether or not somebody's actually really poorly are, as Simon and Alison have said, particularly around respiratory rate, cognition, pulse oximetry, and the overall demeanour of that patient in terms of whether or not, you know, they're, you know, very poorly or not.
Thanks. Some ambulance trusts around the country are asking for a news score when conveying patients. What are your thoughts on that? Simon, would you like to start?
Right. This started before ever we had COVID, and was a joint agreement between the ambulance services chief executives, the RCGP and the BMA all had input into this, and it was agreed where it was practical, the sharing of appropriate physiology or a news score was the right thing to do. It improves communication. The ambulance services may choose to use it to prioritize their response, and that was their suggestion, that patients who scored highly with news would fall into what they call category 2 response, which is an 18-minute response. And certainly when we were doing the sepsis workshops over the last 2 or 3 years, we would get repeated concerns that they had from GPs who'd had the sickest patient they'd seen all year in their hospital, in their surgery, but it still took them over an hour to get an appropriate ambulance response. And some of that came down to their ability to communicate with a non-clinical ambulance call handler effectively. And their very sick patient with bronchopneumonia got converted into GP call chest infection. Whereas if you supply them with really abnormal physiology to back that up and say pneumonia or chest infection with a new score or abnormal new score or abnormal oximetry, you can get a completely different response from them.
And
so just very quickly, yeah, sorry. So what I was going to say just very quickly, because I was involved with those discussions, so it was a specific request, as Simon says, from the ambulance service. So this applies to England, so there's no requirement to do a News 2 score, but you're invited to do so. So I would normally, I admitted a patient yesterday from a visit I did, and unusually a home visit actually these days, and actually, you know, I gave those parameters to the ambulance control staff. So it's as much to help our ambulance colleagues as well as being able to document things. So so that's really where that is. So
and then the other thing I would say, that which is also relevant to COVID, is a couple of years ago I had a patient, a young man, a news of 4. He was a student, international student. I'd arranged an ambulance to admit him. I was more concerned about him, couldn't explain why. And within the 20 minutes, half an hour waiting for the ambulance, he looked more sick, repeated his news, and it had gone from 4 to 6. So he was actually deteriorating quite quickly. And for me, that was really empowering, objective evidence of deterioration. And I was able to call the ambulance service, make him, you know, a priority transfer and pre-alert the ED. And again, it's that track and triggering, because we're often looking after sick patients in the surgery.
And with the volume of people that COVID is affecting, and there being some patients who are deemed as not necessarily to be transferred into hospitals, what other, there's obviously people will be able to monitor people and follow up with them, but is there any other treatment that could be offered in primary care if people are not sick enough to go into hospital but have suspected COVID related?
So for the vast majority, it's a relatively mild. It's not very nice. You know, I've had quite a number of people who've had this. To the best of my knowledge, I haven't, but I do expect to get it, I think is probably the way I put it. I think most of us do. Hopefully I'll be all right, but you know, we'll see at my advancing age. So the vast majority, it is fluids and simple things that we would do. There's a question that somebody said to me, if you get somebody in the care home, about oxygen, you know, certainly there's some evidence that will help symptomatically, but we generally do not have that in the community. You know, so it would be under most circumstances, if you think that the patient is warranted to require oxygen, then it almost certainly it means, you know, transferring them either to a community hospital or an acute hospital. There may be other complications around that. I know that some palliative care physicians had said that using oxygen concentrators would be useful in terms of end of life and palliation and symptom control, but I don't believe that's in widespread use. But I know that had been suggested, but I don't believe that's in. But in general terms, if somebody needs oxygen, you know, for anything other than, you know, the length of one of the small oxygen cylinders that some of us will carry, then in generally they need to go to either a community or an acute hospital.
Great. And speaking of oxygen, there was also a question about the oximeters, and it's great that more oximeters are going to get out to various places. Is there also a plan for implementation? So as academic health science networks, we know it's not enough to just give people a gadget. There needs to be a bit of a plan for how that gadget will be used and making sure that people are properly equipped. Are you guys aware of what's going on around that, or is that something we need to take somewhere else as a question?
So yeah, I can answer part of that. So given the issue we've just been discussing about pulse oximetry and being able to identify particularly those with silent hypoxia, there are plans within England. So this is from NHS England, and especially for care homes, to see whether or not a number, probably 1 or 2 pulse oximeters could actually go to residential homes. And obviously there would need to be training alongside that, because actually as we then dial in, or if they're calling GP out of hours or 111, as we've just been describing, alongside being able to get the pulse, being able to have the pulse oximetry, and very importantly, know whether or not that pulse oximetry has changed. That's probably the, it's not the actual number itself, it's whether or not it's changed from that normal for that patient. So those plans are in place. I don't have the logistical details in terms of when they would go, but there's clearly been recognition of the importance of that. And it would go alongside where many of us would actually be recommending many of our patients, if they've got blood pressure, to have a sphygmomanometer or a thermometer, because of the fact that they would be able to actually then speak to people remotely. And it's that change. I think Alison wanted to say something.
Yeah, I was just going to say the change there for care homes is, I wanted to reiterate the videos which the AHSN network's been involved in developing. So there are 12 videos produced with Health Education England and supporting care home staff on how to take simple observations. So they're a free video resource, and we can share details of that later. If that would help you, share it with your care homes, local care homes.
Simon, did you want to say anything more on that?
Yeah, just to say that I am aware that NHS England are looking at the logistics of how we might increase the use of oximetry in a number of settings, and maybe piloting that in 1 or 2 areas.
Thank you. I think we are nearly running out of time now. Does anybody have any final things they wish to say?
I think just to say that thank you very much for everyone that participated. Please leave us some feedback on the chat function, because that would be really helpful about how we use this going forward. If you've liked it, it is going to go up on YouTube, I believe, later today. So you can ask your friends to look at that, and if they like it, I suspect like subscribe to it, but because we think that there will be need to do this again when the evidence is maybe a bit clearer, or there are new things to talk about.
Thank you. And I'm going to hand over to Jonathan to wrap up for.
So I've just popped in the little chat at the bottom. There was an email address, and there are further questions. And again, there's a huge amount on the RCGP website, Mythbusters, top tips. We've done a lot of work on shielding, which is clearly it's not for today, but it's clearly an area of concern, I think is probably a way of putting it. We've also done a huge amount of work on some of the death certification changes, the verification of people who've died and things like this. So do have a look. There's a huge amount of information on there. So I hope you found this helpful. I would particularly like to thank Simon and Alison, who've obviously done a huge amount of work, but also in the background, I mustn't forget Catherine, who's been doing all the questions. So thank you being the question master for this, but also Bernard Allen and Rahel Gazzetta, because actually these sorts of events don't just take place. You know, there's a huge amount of effort and work behind the scenes. So I hope you found that helpful. We wanted to finish on time. My clock says it is 14:30. So thank you all very much. And I hope you have a good rest of the day, and, you know, given the circumstances, all stay safe. That's very important at the moment. So thank you all very much, and goodbye.